by Dr. K. Subba Reddy sir. Like, I'm proud to say he's one of my initial teachers in critical care. So he's going to talk about early rehabilitation in ICU improves outcomes. Over to you, sir. Sir is the head of the department of critical care medicine at Apollo Health City, Jubilee Hills, and right now he's the current ISCCM Hyderabad chapter president. And sir is the clinical director for APCO's Rehabilitation Center too.
Thank you, Dr. Rajesh, for that nice introduction. And at the outset, I thank Mohan Mara sir and the entire Reflect team for calling us for this fabulous conference and the nice arrangements at Vizag. And Dr. Rajesh already told the conflict of interest. I'm associated with one rehabilitation center, so I'll be talking in favor of rehabilitation in ICU. The way we should rethink the way we manage our intensive care patients. Before we used to sedate, we used to paralyze the patient, keep the patient on ventilator. We never used to mobilize these patients that much. And then that's why we see a lot of rehabilitation hospitals coming up in recent times. And did you hear this rehabilitation hospital 5 years ago? No, we have not seen. And this specialty, rehabilitation medicine specialist, was not there a few years ago. Now, if you look at the US hospitals like John Hopkins, Mayo Clinic and all, they have a physiatrist who is taking rounds in the intensive care unit at least once in a week, and they have rehabilitation staff in the ICU. Rehabilitation is not just physiotherapy. It is a holistic rehab. You have to give cardiac rehab, cognitive rehab, you have to give neuro rehab, pulmonary rehab, and endocrine rehab. Our knowledge, if you go by our classical teaching and all, we know that rehabilitation happens only in neuro intensive care unit, and it doesn't happen in the medical intensive care unit. It is not like that. A patient with septic shock or patient in ARDS can have hypoxia, hypotension, and these patients can have severe lot of neuronal apoptosis, and then they can have neurological deficits, they can have cognitive deficits, and then if you don't provide good rehab for these people, then the length of stay in the ICU will increase, length of stay in the hospital will increase, and finally you have to approach the rehab hospital, and then you have to send this patient to the rehabilitation hospital, and again they will stay in that hospital for a long time, and then we see all these infections in those rehabs because these people with the tracheostomy, they stay for a long time, and then as Dr. Suresh Ramsubban sir was telling about the outbreaks, we are seeing these outbreaks in the rehab hospitals, and the mortality is increasing. So what is rehabilitation? Rehabilitation is, as I told, it's not physiotherapy. A set of interventions designed to optimize functioning and reducing the disability in individuals with health conditions in interactions with their environment. So when you provide, because of the immobility, we see a lot of ill effects for a critically ill patient. And there is a functional decline for a patient who is in the ICU, and then they take long time to come out of ventilator, and rehabilitation provides better long-term outcomes, even the short-term outcomes. The length of stay in the ICU will come down, and the number of days on mechanical ventilation will come down, and these patients will get discharged from the hospital faster if you move these patients in ICU, if you mobilize. So all the experimental models showed there is significant decrease in muscle mass if you don't mobilize these patients. And sepsis and other critical illnesses will cause a lot of metabolic and vascular dearrangements, which is causing damage to the peripheral nerves and the skeletal muscles. And this prolonged mechanical ventilation, we know the effects on diaphragm, and the malnutrition, we don't feed these patients properly, and the malnutrition again contributes for the long stay in the hospital. So the WHO has given the 4-phase process. So the first thing is we have to assess the situation, what kind of patients we need to mobilize. If you get a stroke patient, you mobilize the stroke patient within 24 hours. But if you get a medical patient, septic shock patient, you will not mobilize that patient within 24 hours. So you need to assess the patient, and then you have to develop a rehabilitation strategic plan for this patient in the ICU, and then you should establish good monitoring, evaluation, and the review process, and then you have to implement a strategic plan. In your ICU, you may be having very good protocols for the infection control. You may be having very good protocols for ventilatory management. You have protocols for sepsis clinical pathway, but you don't have protocols for the mobilization, rehabilitation. So, on rehabilitation, if you don't provide, and then we see a lot of post-ICU syndromes, and then we see ICU-acquired weakness in significant number of patients. And what is post-intensive care syndrome? So, this is worsening of physical activity, and this is ICU-acquired neuromuscular weakness, and then it is not about the physical weakness, they can have even the cognitive impairment. And we all know the ICU acquired weakness, the incidence is around 33% to 50%, depending on the type of patient in the ICU. And significant number of patients, they will have cognitive impairment in ICU, and then they develop psychiatric illness, and then that's why we see post-traumatic stress disorders in these patients. So all of us know this ABCD bundle, that is awakening, breathing, spontaneous breathing trials, and then the coordination of the care and communication among various disciplines, and delirium monitoring, assessment and management, and the E is early ambulation in ICU. So in this study, they found if you don't stop the sedation, and then if you continue physio or rehab, so the outcomes are not that good. So you have to stop sedation, you have to give spontaneous breathing trials, and then you have to mobilize these patients. And then you need, if you just provide rehab, that's not enough. You have to, you should have some additional interventions, like if there is any hypoglycemia, you have to treat hypoxia, all these things we do routinely in the ICU. And then the nutrition, we have to concentrate on nutrition for better outcomes. And we all know what is ICU acquired weakness, and then we know the critical illness myopathy and critical illness polyneuropathy, and we know the risk factors for developing this ICU acquired weakness, and then we have monitors to find out ICU acquired weakness. So this is a hand grip dynamometer, and you need not always depend on muscle action potentials or sensory node evoked potentials and all. And then we can assess with a simple questionnaire, and then we can medical research council score also you can identify ICU acquired weakness. And then finally we depend on the electrophysiological investigations. So to prevent this, we have to go for early rehab. So you should know when to start this rehabilitation and when to stop this rehabilitation. What is the criteria for stopping, when to stop? Is there drop in GCS, or sudden sudden onset of hypotension, or vasopressor requirement has gone up? Then you will stop mobilizing these patients. And then this post-intensive care syndrome will leave us with a lot of sequelae. We have pulmonary sequelae, cardiovascular sequelae, endocrine sequelae, and we need to prevent these sequelae by mobilizing these patients early. So if you look at one hospital protocol, and most of the hospitals nowadays we have this protocol. The first step is you take care of your lines, the patient lines. Even we try to mobilize a patient who is on ECMO, we give the ergometer to the cycle ergometer to the ECMO patient, and then we ask the patient to do cycle ergometer. For that, you need to entangle all the lines, and then we should do first we should assess the patient, and we have to do bedside exercises, because you don't know whether the patient has trunk control. If you start mobilizing these patients, and then if he doesn't have trunk control, or if he has vestibular dysfunction, then we'll face problems. And then slowly make the patient to sit on the edge of the bed, and then you have to assist him to stand if there is a proper trunk control and the neck control. And then you have to, in the final step, you have to slowly make them walk. So when to mobilize these patients? If you mobilize these patients, in this study they found you can shift the patient to the ward early. And we are fortunate, we have physiatrists since last 15 years, and then that physiatrist recently moved to Medanta Institute. Then we had to recruit one more physiatrist, and this physiatrist, it's not possible for him to do ICU rounds every day, but they do rounds once in a week, and then they see whether we are doing properly or not. But you have to assess, the assessments will take long time. So in the studies, they said you have to mobilize these patients within 24 hours, but you have to first do the proper assessment to start the proper rehabilitation plan. And then you should know the physiological reserve of that patient before coming to the intensive care unit. So even if you just make the patient to sit on the edge of the bed, there are a lot of positive effects. And then they can have better trunk control, faster trunk control, and then they have better GI mobility, and they can even these people, the lung volumes also will get better. This is our hospital. In our hospital, we have this robotic equipment. This is called Erigo. It gives movements to the lower limbs, and then you can put him on the erect table, and then you have to monitor him very closely. All the tracheostomy patients, when we use this Erigo, we are able to decannulate them faster, and it prevents osteoporosis when you try to mobilize, when you do this Erigo for immobilized patients. And when you're shifting these patients, you have to be very, very careful. You have to use a hoister if you have hoister. Otherwise, you have to shift them carefully. Otherwise, we see dislocation happening at the shoulder when you're trying to shift these patients. So as I told, we have cardiac rehabilitation. In the cardiac rehabilitation, you should know the criteria for the cardiac rehabilitation. The patient has to be stable. Then you can use these ergometer, and then you can use these upper body aerobic exercises and all if the patient hemodynamically stable. And pulmonary rehabilitation, we all are masters in pulmonary rehabilitation thanks to COVID. So we have very good pulmonary rehabilitation programs in most of the hospitals. So we use incentive spirometry to improve the lung volumes, and then for mobilizing secretions, we use a cappella, and then we use postural drainage and high frequency oscillations to prevent, to mobilize secretions. So we need to look at the endocrine rehabilitation. If you just do mobilize these patients, it's not enough. These patients are in ICU for longer times. They're not exposed to sunlight, and then there's a role for vitamin D supplementation, and then you have to provide good nutrition, and then you have to assess the diabetes status, you have to assess thyroid status, and then you need to take care of these endocrine issues, and then we have to mobilize these patients. So neurologic rehabilitation, like if you are working in a neuro-intensive care unit, you have a very good neuro-rehab protocols, but even in medical intensive care unit, we should never, as I told, there is significant amount of neuronal apoptosis in these patients, and we should have proper neuro-rehabilitation, even the cognitive rehabilitation. We have to involve a psychologist, and then if the patient requires psychological intervention, then we need to call the clinical psychologist. And then we can use neuromuscular electrical stimulation, and this is the neuromuscular electrical stimulation to improve the outcomes. So what is the evidence for this early rehab? So in this study, when they used early cardiopulmonary rehabilitation, again they have seen the ICU, they have seen the outcomes. The ICU discharge is faster, and there is lower mortality in these patients, and they have significant reduction in ICU readmissions. If you look at the Kaplan-Meier curves, and then there is mortality difference, and then when there is a difference in readmissions when they mobilized these patients early. So this is another trial, that is EVERT trial in stroke patients. In this group, they have mobilized patients within 24 hours. Is it possible in all our hospitals? No, it is not possible. Assessments only will take one day. You have to do nutritional assessment, you have to do physiotherapy assessment, and then we do social assessment. We do a lot of assessments, and then this takes at least 24 hours to stabilize the patient. But in this trial, they did mobilization within 24 hours, and then they found better results. And then again, early exercises, not only the long-term effects, you have the short-term functional outcomes when you mobilize these patients in ICU. And then in these 6 randomized control trials, they analyzed, and then they gave the meta-analysis, and then there is significant reduction. If you go for early rehabilitation, you can prevent ICU-acquired weakness, and then you can see better MRC scores if you do early rehabilitation, and you can prevent post-intensive care syndrome in these patients. So again, this study was done in China. This is high-intensity physical rehabilitation later than 24 hours in the post-stroke. I told within 24 hours, and in this study they have done after 24 hours, after their proper assessments, they have done rehabilitation, and in this study also they found better results. Even if you can't mobilize within 24 hours, you have to mobilize within after 24 hours. And then we have a lot of equipments, new equipments. We have robos. to mobilize the patients. So we have new gadgets for ICU like that. We had to buy these rehabilitation equipments for the intensive care unit. This is Locomat, which was bought in Chennai Apollo 10 years back. So that time we never had any kind of mission like this in our hospitals. Now recently we bought much advanced machine than this, that is exoskeleton. With the help of exoskeleton, you can mobilize a patient who is quadriplegic, and these patients will have better they will have better outcomes if you use these robotics early in the ICU. And are there any medicines along with this mobilization? We can use a lot of medicines, and then is there any evidence? This is a very good trial, and a lot of people know about this trial. This is FLAME trial. This is using fluoxetine. We know most of the stroke patients, most of the ICU patients, they will have depression, and then we use different antidepressants. When they used this SSRI, that is fluoxetine, and then they found there is improvement in the motor recovery in the stroke patients. So this is FLAME trial, the fluoxetine for the motor recovery after acute ischemic stroke, and they found better results in this trial. And then we have music therapy. I don't know whether it is really possible in our intensive care units. We tried this not in the intensive care units. We got one person to play violin in the hospital, and then he sits in the lobby, and then he was playing violin. But like the patients were not taking it in the right way, and whenever there is some mortality or something, they don't like these things. So I don't know, but this is not loud music and all. This is very soft music. I think for better sleep hygiene and for better for the relaxation of the patients, we can use music therapy in the intensive care units. In this study, they found benefits. And there are a lot of other experts. Dr. Arandam Kaur is also there. He is also like interested in rehab. He has a lot of experience. I heard his talk about early rehabilitation in ICU previously, and other people also can contribute. So to conclude, the rehabilitative care will definitely, if you provide good rehabilitation for ICU patients, we can reduce readmissions. We can like length of stay in the ICU, length of stay in the hospital will come down. We can prevent ICU acquired weakness, and there are a lot of good effects, and these patients will go out of your hospitals, and then they will go and the activities of daily living, they can go ahead after the discharge. Otherwise, if you don't provide this care in the intensive care units, then they will go to the rehab hospitals. And I have seen when they go to rehab hospitals, because the standard of care in our country still is not very good, they come back with again some multi-drug resistant infections to the intensive care unit. So thank you so much.
Thank you, Dr. Subba Reddy. And you have a state-of-art rehabilitation center, so you are able to translate the services into your intensive care unit. And we also, as you mentioned, we need to learn art of mobility medicine. I think that will improve better outcomes in our ICUs also. In view of time constraint, 2 or 3 questions are allowed, please. Questions, please.
I think all of us mobilize patients, there are no doubts.
So, sir, Dr. Suresh, sir, if a patient having patient in the intensive care unit, if a patient, I think around 3 or 4 pseudomonas or acinetobacter E. coli Klebsiella, this is an outbreak. It is an unusual number in that week or 10 days or 15 days. So,
because I told you Acinetobacter, Pseudomonas, these are hyper-endemic. So it depends on what is. If you've never seen a Pseudomonas and you get a Pseudomonas, I would call it as an outbreak. But if you're seeing Klebsiella and Aceneto and Pseudomonas, but then suddenly it rears its head, difficult to call it as an outbreak per se. It's basically hyper-end, because these are all endemically present in our all high-touch surfaces, water faucets. And things like that. So it becomes very difficult to say whether it's an outbreak. But yes, you can do it.
Because unusual occurrence of incidents.
Correct.
So
the definition is anything that is out of the ordinary.
Yes. So you identify these these organisms as per the sensitivity pattern, one. And do you do any other analysis to identify that the organism is the same?
You can look at genetics. If you really want to look at it, whether it is one single, like in this instance that I gave you, if you want to, I didn't present the whole NEJM paper, but they have done the complete genome analysis of all the Candidatus to say it is one single clade. So you have to prove it is whether it is a single clade or is it multiple things that are happening. So if you have Pseudomonas, you might have 2 or 3 different genomic variants going around there. So that tells you that this is a contamination of the environment rather than a true single clonal outbreak. So you have to ensure a clonality, and clonality means you have to do the genetic studies along with it. So you have to get somebody with the ICMR or somebody involved who can do the genetics. Otherwise, it's not possible for you to say whether it's a single clonal outbreak. So if you look at the initial early Acinetobacter studies in the New York state, they all looked at one single clonal outbreak. What we will see is different clones. One belongs to Dr. Suresh, one belongs to my other colleagues, and so on and so forth.
Okay, thank you, sir.